So it's a privilege to announce and introduce our next speaker, Dr. Bridgette Wilson. So Bridgette is a specialist gastroenterology dietitian and an academic researcher. Bridgette has completed her PhD in gastrointestinal disorders and has completed several postdoctoral research projects at King's College in London in IBD, IBS, and functional bloating. So over to you, Bridgette.
Thanks. Okay, so got the clicker here. Yeah, so thank you so much for inviting me again to speak on this rather large project that I embarked on towards the end of my PhD, actually. I started this was my first postdoc project. I was working with Dr. Miranda Loma and Dr. Catherine Wall on collating the evidence to write nutrition and IBD guidelines. So over the last few years, there have been a number of different guidelines that have come out. So there's the BSG guidelines that have come out, which are very medical as well as some of the dietary side of things. There's the ECHO guidelines, which came out in 2020. There's our guidelines, which came out last year. And then more recently, there's been the updated SBN guidelines that have come out as well. In the interest of time, I don't have a very large time slot, so I'm going to be focusing on the ones mostly that I worked on, which was the BDA consensus guidelines on the nutritional assessment and treatment of patients with inflammatory bowel disease. So I think it's a caveat with these guidelines to say that the level of evidence for dietary management is generally quite poor when we look across the board for dietary intervention in inflammatory bowel disease. But the guidelines have been formed by the evidence that is available, so we tried to be as inclusive as we possibly could. And then we put it out to expert consensus, and I know there's probably a number of people in the room who helped with that, so thank you so much. I think there's been mention about the importance of involving patients in their own care and planning and you know, developing things for patients. Kate definitely spoke about that. There was a patient panel with so patients who had IBD as well as healthcare professionals who worked in the field and dietitians. And from that, there were 16 research questions that were asked that it was sort of decided this is what's important to healthcare professionals and patients, and this led to 17 research topics. There was a lot of papers identified because there was that many systematic reviews that we had to do. From all of the over 23,000 papers we went through, and we used 167 different research papers for the evidence summaries. We came up with the evidence summaries for these different questions, and then we took that through something called an eDelphi evidence review, which is where we send out what we think is reasonable, and then people tell us whether or not they agree. And so we get a level of agreement from the patients and healthcare professionals that we send those evidence statements around to. So we took it to 3 rounds of voting, and we came out with 14 grade statements, so those were slightly higher evidence. And then 42 practice statements. So these were things that might not have had the best evidence, but we felt they were really useful and practical to help people working in this field. So we came up with what we hope is a really practical advice for evidence-based practice. Now, I'm not going to read all of this very text-heavy slide, but it's just to tell you these were the research questions and topics that we sent out to answer, and they're divided into kind of different categories. So first, we were looking into nutritional assessment, malnutrition, and how we could treat the symptoms of malnutrition in IBD. We wanted to look at nutrition as a treatment for IBD, and this was a big topic, so we split it up into people with active IBD, so how could nutrition treat active IBD? How could it be used as an adjuvant therapy? So could you use nutrition alongside biologics to make them more effective, for example? How could dietary interventions help with maintenance of IBD remission? And how could it help with strictures? We also looked at surgical aspects, because if you're working in this field, you probably know that there is some evidence out there for using various nutritional methodology for helping with optimizing surgery for patients with IBD. So we've answered this, and also fistulas. And then there's kind of special IBD conditions like functional symptoms, ilioanal pouch inflammation, short bowel syndrome. Stoma is always a bit of a grey area, but we feel like we've given you at least some solid guidance on that. Extraintestinal manifestations, OFG, or orofacial granulomatosis, which, unless you know what that is, you don't know, but it's quite specialist, but it is quite common in IBD. And then upper GI Crohn's and rectal IBD. So that's kind of what we covered. So this is a summary of the systematic review that we did. So you see there were some areas like in nutritional assessment and also the induction of remission and maintenance of remission that we were able to include lots of studies because there's been lots of research in these areas. But there were some areas that actually within stomas, short bowel syndrome, extraintestinal symptoms and upper GI Crohn's and perianal symptoms, we didn't find any studies that matched our inclusion criteria. We did try to be really broadly inclusive, but this just shows like there is an evidence gap here. We have tried to address that with practical advice though. And that's what the Delphi process is really helpful for, because it's, we had 55 experts and patients kind of voting and saying, yes, that sounds reasonable, that's a good practice statement. So I don't have the kind of time to go through everything, but I just wanted to show as an example of some ways that we've tried to be helpful, even though we didn't manage to find any evidence that fit within our criteria. So with stoma, we actually came up with 3 different practice statements for stoma. So that appetite may be reduced, that patients with stoma should really still be encouraged to eat dietary fibre, and that they should have a wide variety of foods, but that some foods could cause symptoms. And then throughout the guidelines, we've got lots of these kind of practical use tables. So this one's on foods potentially leading to symptoms associated with stoma. We've tried to put lots of these in because we know that they're helpful and they're a quick guide, so you can kind of reference to these and say, okay, I'm dealing with a patient with stoma coming into clinic today. What should I tell them about diet? And that's what we hope these guidelines will be useful for, because we are very aware that not every centre in the UK has got a specialist IBD dietitian, and one of the main aims of these guidelines was to try and create more equality of care across the UK and hopefully wider than that, despite not having enough IBD specialist dietitians. So we hope that the advice is really practical. I did want to talk a little bit about nutritional assessment, because this is really important in IBD. Lots of things are important in IBD, but it is important that they are assessed properly. So all newly diagnosed patients should have access to a dietitian, IBD dietitian or otherwise. And nutritional assessment is not just kind of diet history, weight, BMI kind of things. It should include serum micronutrients. Obviously, a dietitian, where possible, should take a detailed diet history, and body composition measurements should also be part of that. So BMI isn't that useful in patients with IBD, and I think it was again Kate who mentioned, body size in these patients is not the marker of malnutrition. People can be really malnourished with IBD, no matter what their BMI is, so even at larger BMIs. And that's why body composition measurements are a really important part of the assessment. So I thought this was a useful practice statement. Obviously, I can't include all, but this one I thought was helpful because it does outline what serum micronutrients we would like to see in an initial assessment of someone with IBD. And this is something that you can now say, please can you order these bloods to the GP or to the gastro or whoever, because it's actually within the guidelines. So can we monitor and correct these bloods if needed? Nutritional assessment as well, like I say, we don't want just BMI. BMI is easy to do, but it often misses things like loss of lean tissue mass, which can be one of the leading causes of fatigue, etc., in people with IBD. So we sort of reference strongly this other paper by Alicia Sandel, and the other 2 authors on this paper are Kath Wall and Miranda Loma. So there's a bit of cross-referencing to this article, but it's a really practical guide with these photos, which I actually took, of Alicia measuring her sister. data and showing you how to do these different non-BMI related measurements. And within our guidelines, we've also got one of these tables that gives you the reference ranges for hand grip strength for men and women at different ages. So that was something that we couldn't find anywhere in the literature. So we thought that'll be useful. Let's make one of those and put it in the guidelines. So because you'll get a copy of these slides, I thought I'll mock up kind of a crib sheet for what an initial assessment for someone with IBD might look like. So you've got the different micronutrients. I haven't gone into it too much, but with iron, with serum ferritin and transferrin saturation, there's slightly different reference ranges if they have got active inflammation. So I've put that into there just because that's helpful. And at the end of my talk, I've included a few extra slides that goes into a bit more detail about that. Obviously, a full diet history is important. Perhaps looking at some of the things like calcium intake as well, because we know that in these patients, that's a really important nutrient. Oily fish is one of the things that is sort of recommended. Actually, oily fish rather than fish oil supplements seems to have a better recommendation. And then body composition measurements, whatever you're able to do, really, but preferably more than just BMI. So because this is a dietitian conference, I wanted to talk about the practical dietary box that we do have on diet. So we feel quite strongly that we should discourage self-directed and non-evidence-based exclusion diets because they can promote nutritional deficiency and low diet quality, and we don't want people getting fearful of food. And at the moment, the evidence isn't really strong enough for any one specific diet to say, yep, that's the diet you should follow if you've got IBD. But we do say that if people have got stable inflammatory bowel disease, then they should include a general healthy eating diet. And also for structuring inflammatory bowel disease, we want to say that soluble fibre is okay. So we also have a table on probiotics. I don't have lots of time left, so I won't go through all of this, but it's just to outline that there is another practical table on probiotics, and then I'll summarise because I think I'm running out of time. So we hope that this is a practical guide to help provide patients across the UK and further afield with the same level of care. The assessment's really important, so I did choose to include a bit more on that. And it should be patient-centred and account for disease location and the level of inflammation. And like I said, there's a number of other guidelines, but the messaging is all very similar. There is some debate about the evidence for using various treatment diets, but I won't cover that here. And also, you know, if you're not part of the MDT on IBD, try and get in there. So thank you very much for listening, and thank you to the people that funded this.
Thank you, Bridgette. That was really insightful and included lots of practical guidance out there for the dietitians watching. So I think we have a couple of minutes if anyone wants to. No,
no,
I'm getting.
I've run over. Sorry. Thanks.